Good morning, everybody. I know it's going to be a busy day on the ward, so thank you all for coming. It's my pleasure this morning to introduce our guest speaker, Nikita Goswami, who's also consulting on a bunch of purple team patients this week. Dr. Goswami is a pediatric rheumatologist here at Phoenix Children's Hospital. She went to college at Youngstown State University and then went to medical school at Ross University of Medicine. She went on to complete her pediatric training at the Carillon Children's and then a rheumatology fellowship at Children's Hospital Los Angeles in 2020. In an effort to improve the quality of stay, length of stay, workup, and patient treatment, Dr. Goswami, with the help of her colleague, created the chronic recurrent multifocal osteomyelitis protocol. She's created a multidisciplinary clinic with physical therapy for patients with juvenile dermatomyositis in an effort to provide optimal evaluation with the goal of improving disease control. She and her husband enjoy spending time with their 9-month-old and their golden. And in her free time, she enjoys traveling, crafting, and catching up with friends and family. So at this point, I'll ask Dr. Goswami to come up here, and her topic today is going to be on, whoops, okay, we got that. Topic today is going to be on the black, white, and grays of systemic lupus erythematosus.
Thank you. Good morning, everybody. So yeah, my topic is going to be about the black, white, and grays of lupus. This was something I had asked, like, what would you guys like to learn about more and have more knowledge about? Because it is a common diagnosis we see on the inpatient side that is frequently a little bit difficult to navigate through and get rheumatology involved. So I figured I'd give you a good background. Oh, sorry, I have no financial disclosures. The objectives of this talk are to evaluate a few case presentations at the beginning with patients with a diagnosis of lupus or with concerns for lupus, identify symptoms and signs of systemic lupus erythematosus, formulate differential diagnoses, analyze lab studies to confirm the diagnosis, and utilize diagnostic criteria to identify patients with lupus. So the first case, I have an 8-year-old male with fever, abdominal pain, fatigue, myalgias, chills, intermittent rashes, and headaches. Initial labs at presentation showed a little leukopenia, a little bit of neutropenia, but not quite, a little anemia, as well as thrombocytopenia, elevated ESR at 83. He had a normal chest x-ray and an ultrasound of the abdomen showing splenomegaly and debris in the bladder. In this presentation, what are some of the differentials that you guys would think about? What did you say? Other concerns? We have pancytopenia. What are some things you think of with that? Nice. Yes. Okay, so I'm going to give you guys a little bit of help. So leukemia is going to be one big thing to always look for with pancytopenia. There can be post-viral marrow suppression, HLH or hemophagocytic lymphocytic histiocytosis, and then lastly, systemic lupus. Case number 2, so we have an 11-year-old female presenting with fever, joint pain, petechiae, and feet swelling. She had a urine showing 1+ protein and 2+ hemoglobin. CBC shows a white count of 3.1, so a little bit leukopenic, a little anemia as well at 10.7, platelets at 163, and an ESR, again, elevated at 74. She has a normal EKG. What would be your differential in this scenario? We're saying the same. So looking at this case, obviously, I would think a little more HSP at the beginning, maybe with the petechia and the feet swelling, joint pain. She's a little bit older in age, so that's where I was like, I don't know. And then the thrombocytopenia doesn't make sense. So that was the first differential actually for this patient, and then post-strep GN, and then lastly, systemic lupus. And case number 3, so we have a 10-year-old female, again, presenting with intermittent fevers, lymphadenopathy with large periaortic lymph nodes on ultrasound, which was confirmed by a PET scan. She had elevated inflammatory markers again, as well as transaminitis with a positive ANA and SSA, however, negative double-stranded DNA and Smith and SSB. Her CBC again showed some anemia and a little thrombocytosis, again, borderline with normal ANC and ALC. Any differentials for this one? All right, so the lymphadenopathy is like the key point. I want you guys to pay attention to this. We'll talk about it a little bit in the future, but so lymphoma is something you always want to worry about with anyone that has prominent lymphadenopathy. Another thing is Kikuchi syndrome, Castleman's disease, and then again, lupus. So let's dive in. Everyone always worries about this test. So there's a positive ANA. So ANA stands for anti-nuclear antibody. We can see it in about 20 to 30% of the healthy population that can have it positive without an underlying rheumatologic condition. Viral infections can be associated with the transient appearance of the ANA. So examples being parvovirus, EBV, CMV, herpes virus. Sometimes the viral infection could be kind of like the initial presentation of these patients as well. So that's where it's a little bit more digging that you have to do with their presentations. So in any patient with lupus, you should definitely form a good broad differential because a lot of times, like we just talked about, infections can play a role. So the viruses that we listed earlier, but then also we want to rule out things like malignancy, Kikuchi-Fujimoto disease, Castleman's disease, Evans syndrome, or ITP. And then we'll leave it at that. There's obviously way more, but those are the most common ones that you would want to definitely think about. So going into the epidemiology, these patients' incidence is usually about 3 per 100,000. Prevalence is based on ethnicity. So we definitely see it more in African-American, Hispanics, and Asians. And the age of onset is usually around 12 years of age. It is rare to see this in less than 5 years of age. So when you have those patients that you're like, some kids will have a positive ANA under the age of 5, but that doesn't mean they have lupus. They just have that positive ANA. And that's where we kind of monitor them outpatient for those scenarios, unless they have other physical manifestations or clinical manifestations with serologies that tell us otherwise. But generally speaking, that is the most common scenario. And again, there's more female to male predominance, about 5 to 1. So etiology, usually there is an alteration of the innate and adaptive immunity. This can include complement deficiency, genetic overproduction of interferon alpha, apoptosis defect, or abnormalities in B, T, or antigen presenting cells. They usually result in increased production of antibodies and hypergammaglobulinemia. Going to the genetics, so about 10% of first degree relatives are diagnosed with lupus as well. There's a 20-fold increase among siblings having lupus. And then 1 in 10 family members of patients with lupus have another form of a connective tissue disease. Now, when people say connective tissue disease, this does not mean Ehlers-Danlos syndrome. I feel like that's a common misconception. That would be a different form of connective tissue disease. We're talking more in the autoimmune sense. And then 90% of patients usually are homozygous for C1q deficiency. 1/3 of patients are usually homozygous for C2 deficiency. And then of course, C4 deficiencies can be associated with increased risk of lupus. So a lot of times when these patients come in, you'll see their C3 is low, but then their C4 is like in a single digit at like less than 5 or 7 or whatever the number may be. But we always wonder, like, did those patients have low C4s? We just didn't know until we went chasing the labs to be like, oh, they actually have a new diagnosis of lupus. It's possible they actually had it, just didn't know it. And then hormones play a huge role. Estrogen increases your risk of lupus in general. We generally see going through puberty or menopause is a big time frame for seeing a lot of the new diagnosis and presentations. And so I was going to sidestep into drug-induced lupus. I didn't want to delve too far into it, but give you background about it. It is something we do see. It's a milder disease manifestation, usually occurs after several months on treatment. 90% of the cases usually have a positive anti-histone antibody. Common medications including hydralazine, procainamide, isoniazid, methyl-dopa, quinidine, minocycline, and chlorpromazine. Sometimes there can be a lack of reversibility. So in these scenarios, it usually means the drug has unmasked the underlying lupus, and that is possible. So that's where we kind of monitor the patients as they wean off the medicine, see how they do, try to help them recover if they can. If not, then we're like, okay, you're no longer a drug induced and you're actually just a formal diagnosis of systemic lupus. Generally speaking, symptoms do improve with discontinuing the medication, but sometimes they do need a little bit of steroids or immunosuppressive medications for support. And then say they are re-exposed to the medication in the future, usually the symptoms will come on a little bit sooner. So rather than months, it's usually a few days. I did include a table here, so there is an extensive list of medications that can cause drug-induced lupus. This is just part one. I am not going to list all of them and read them to you, but you can kind of see there's a good variety of medications. I think seizure meds are a big one that we see in the pediatric population. Ethosuximide is something to always keep in mind. And then sulfasalazine, there's a lot of different ones on here, but those are ones that I have seen patients on during my time even just here. Moving to environmental, so viral infections, like we said, can trigger a lot of patients' immune systems kind of go into this overdrive and then leads to the slow effects of the immune system attacking different parts of their body. Common infections being EBV and CMV. UV light exposure is a big trigger as well. So UVB rays usually trigger the keratinocytes to release chemokines and cytokines, which then leads to T cells and dendritic cells under the skin to go through the apoptosis process and then necrosis of the keratinocytes, which decreases DNA methylation and can alter the gene expression. So that's why we always hear about people with photosensitive rashes in the setting of lupus. We say, wear sunblock because those UVB rays are the bad rays, right? Board question. So that's something to think about. And then going through the clinical presentation. So general symptoms patients present with are the big symptoms that everyone's always worried about. We don't know what this is. Fever, weight loss, fatigue, loss of appetite. Usually the symptoms are persistent or worsening over several weeks to months. So it's not usually a very acute presentation. However, you may feel otherwise when you're on the inpatient ward. Some of these patients come in with like a week of symptoms and you're like, has it really been a week or has it been longer? And that's always the gray zone, but something for all of us to dig through a little bit more. In general, the pediatric population have a little bit more severe disease than adults. Usually they'll present with one organ system involvement, but over their lifetime, right, there's more risk of having the waxing and waning nature of their disease, so they can have more organs involved as they go further along during their course of their disease. Okay, so this is where I kind of give you an intro of what I'm going to talk about. So we're going to look at the different clinical disease presentations involving the renal, mucocutaneous, musculoskeletal, neuropsychiatric, cardiovascular, thoropulmonary, hematologic, vasculitic, GI, and hepatic, as well as endocrine. I will try to not bore you, but if you guys have questions along the way, feel free to ask. So this was a question someone had to ask me. So isolated chronic fatigue is usually like without any other physical findings are rare to see in lupus patients at diagnosis. I think a lot of people have this perception like, hey, they just have this chronic fatigue and nothing else could it be lupus. You get lots of referrals outpatient for it, even questions from the inpatient side as well. And usually you will need other symptoms and you will be able to use the criteria, which I'll get into a little bit later to help you with that too. Okay, so the big one, you will see a lot of patients come in the inpatient side here with lupus nephritis diagnoses. So what does this mean? Usually renal disease can be seen in up to about 75% of kids. The hallmark histologic findings is called a full house pattern. They usually have a positive IgG, IgM, IgA, C3, C1q, and kappa and lambda chains seen on the histo. The symptoms can be silent or they can be presenting with minimal clinical or lab findings as well. So we generally encourage the biopsy to be performed early because then we can minimize the disease progression based on the medications that we're using to treat their condition. So how do you make the decision about the biopsy? Usually these patients will have an elevated creatinine without alternative causes such as medication, sepsis, hypovolemia, proteinuria of 1 gram or greater per 24 hours. However, other reasons to look into biopsying would be if they have proteinuria with 0.5 grams or greater per 24 hours with hematuria, or 5 RBCs or greater per high-powered field, proteinuria of 0.5 grams or greater per 24 hours with cellular CAS in the urine. So I kind of just gave you the quick blurtle here. You can see there's different classes of the lupus nephritis, 1 through 6, 1 being the minimum and 6 being the most advanced stage. Just to give you a little background, so class 1, usually they have mesangial immune deposits seen by immunofluorescence, very minor changes. Class 2, you'll see the hypercellularity in the mesangium, which is where you see the mesangial-proliferative lupus nephritis. They usually have a few subepithelial and endothelial deposits. Class 3 is focal lupus nephritis. This is usually when less than 50% of the glomeruli are involved, and then they can kind of have focal, segmental, or global involvement depending on the case. And then class 4 is diffuse. They usually have more than 50% of the glomeruli involved. Again, similar presentation. And then lastly, class 5, membranous lupus nephritis is usually seen with, again, global or segmental, but they have subepithelial immune deposits or morphologic sequelae. So generally speaking, class 5 is kind of unique. It can present with patients with it can be a mix of class 3 and 5 or class 4 and 5. So there can be some overlap. And I don't want to overwhelm you, but usually you can have presentations from 3 to 4 or 3 to 5, sorry. It can be acute or active or chronic, sorry. So it could be very acute inflammation versus it's chronic disease. So it kind of can help us decipher, okay, this is like very active, we need to treat it hard versus it's chronic, it's already damaged and sclerosed, and we don't know how much more we're going to be able to reverse, but at least how can we prevent any further progression? So that's kind of how we decide our medications. And then lastly, class 6 is when they have advanced sclerotic lupus nephritis. Usually these patients are about 90% or more of their glomeruli are globally sclerosed. So it's usually irreversible. These are the patients you'll see most likely on dialysis and needing to potentially get a kidney transplant. Before I move further, when do you consider repeating a kidney biopsy? That is something we do to try to optimize our management. So you would consider this, obviously, if they're seeing more proteinuria, worsening kidney function, new urine sediments, or if they're having a flare of their renal disease after they were responding and recovered from previous treatments, then it's kind of like maybe their disease has progressed and we need to use a different medication or stronger medication. So moving on to the mucocutaneous. So as you know, the most common one that a lot of people worry about is that malar butterfly rash, but there are other forms. So look at the discoid lesions, which I'll try to pop up here. There we go. Discoid lesions. Here is a picture of a discoid lesion seen on the palm, the ear, and the scalp. It's going to look very different in individuals of different skin tones. So this is just an example of someone with darker skin tone. In Caucasian, you sometimes will see it's more like got like a necrotic, like purplish looking to it. So it's a little deeper, a little angrier looking rash, and it can be a little bit worrisome in terms of the presentation, but sometimes it's just that erythematous and deep rash as well. Annular lesions can be seen, nail bed capillaries. I wanted to point it out. So this is not for a lupus patient, but it is a good example of nail bed capillaries. So you can see kind of like the periungual erythema, and it's a little bit diffusely puffy. And then here you can see the capillary dropouts and enlargements and a little bit of tortuosity as well. And I'll move that picture for a second. So livedo reticularis is something we can see. It's again really vague and hard to know. I feel like you see a lot of patients with that, but it's something that can be seen in lupus patients. And then oral and nasal ulcers. So a lot of patients with lupus will kind of be asymptomatic. They don't really know they have ulcers, and you go and look in the roof of their mouth and you're like, oh, you have some ulcers. Did you know that? And they're like, no. So majority of the time they can be painless, but you can also have painful oral ulcers that are sensitive with different like citrus, acidic foods, and spicy foods. So sun avoidance is key. We usually recommend using sunblock with SPF of 30 or higher, hats, long sleeves, sun guard, clothing, umbrellas, etc. If their kids are in school and have recess, we usually provide notes to excuse them during those peak UV rays. So this is just malar rash. I'm just showing you 3 different versions of it. Obviously the textbook one, I feel like this is the most common one we see. It goes over the cheeks and nasal bridge and spares those nasolabial folds. However, it can look different in everybody. So this is an Asian patient. You can see that it's more like a flushing with some telangiectasia appearance, but it does definitely still go from the cheek over the nasal bridge. And then this one's a little bit more severe in like a Hispanic patient. And you can see there's more flaking and peeling. So it can present very differently in all different patients and ethnicities as well. Going further, musculoskeletal. So these patients usually have arthralgias, myalgias, myositis. Well, makes it a little bit difficult when you have these patients. Sometimes you can see that they will have an elevated CK and you're like, oh, is this because they have myositis or is there something else? So if it's not myositis, other things that can cause that would be like a steroid-induced myopathy or a drug-induced myopathy. So that is something to always take into consideration if they're on medications and then they're developing these symptoms. Versus alternative things, we see a lot of arthralgias and myalgias overlap with lupus patients is central sensitization syndrome, or you can have other names of amplified pain syndrome, chronic regional pain syndrome. So a lot of those patients do overlap with our patients, which makes it difficult for sometimes to know is this their underlying disease activity or their pain. So going into neuropsychiatric, I think this is one of the more important things to be able to identify in patients. Most of the patients will present with headache as the most common symptom. Sometimes it can be a migraine, sometimes it can be so severe, unrelenting headache that requires narcotics. Secondly, so going through the other ones, psychosis, you can have auditory or visual hallucinations in a neuropsychiatric lupus patient. It can be pretty severe. As they receive treatment, their symptoms do improve. So usually these patients do have like sitters in their rooms, and you're kind of monitoring them closely every day as you start the treatments to see their response. They can have some cognitive dysfunction. You will have subtle abnormalities coming through with patients and parents complaining like, I can't think straight at school, and teachers are noticing there's like a slight downgrade in their performance. So that can be affected. There can be mood disorders also with depression, anxiety. Cerebrovascular disease can be seen with vasculopathy of small vessels and vasculitis of large vessels. So that is something we see commonly as well. And then seizures. So this is always a little bit of a difficult one to decipher what it's from. Is it from their lupus and they're presenting with this in the neuropsychiatric form, or is it from they have really active renal disease and having high blood pressure and then presenting with PRES, which is posterior reversible encephalopathy, and usually you would do further brain imaging with an MRI to kind of delineate what it is. Movement disorders, I have yet to see a patient with a full presentation of lupus with movement disorders, but you can see some chorea with basal ganglia involvement, and then also can see some dystonia and Parkinsonian type movements. And then lastly, peripheral nervous system. So the major one that we worry about with this is transverse myelitis, but we can overlap with a little bit of Guillain-Barré syndrome as well as optic neuritis. All three of these require very rapid intervention because you want to reverse them immediately so they don't have any lingering defects. So workup for neuropsych lupus, most commonly we will start with the lumbar puncture, getting the CSF protein, illegal clonal bands, and plus or minus anti-ribosomal P antibody. This one has been shown in studies to be helpful in giving us more data for lupus involvement with their presentation. However, there are times it is involved and they don't have the antibody and vice versa. So it's a plus or minus because of that. If you have enough CSF, I would say send it, but if you don't, it's okay. MRI brain, like we talked about, and then you can also use CNS SPECT or PET scan as well to further evaluate. And the CNS PET scan will be helpful to look further into psychosis versus vasculopathy. So is this from lupus psychosis, and that's what's causing it? So we use that data as well to help with it. Moving on to antiphospholipid syndrome. So this is usually seen secondary to lupus. It can be seen in other medical conditions of ours, including overlap syndrome, vasculitis, and arthritis. About up to 70% of cases usually have some form of underlying autoimmune disease. Most often, you'll see the lupus anticoagulant being the positive antibody, and about 50% of patients suffer from a thrombus within the first decade of diagnosis. Hydroxychloroquine usually has a protective effect, and of course, if they have a thrombus, they usually use heparin. A lot of times we get asked the question, like, do you use aspirin in these patients? There's controversial data out there about that. Previously, everyone used to be like, yes, start aspirin, you know, it's going to be protective. However, over time, data has kind of shown us it doesn't work as well, and we kind of just monitor these patients. But if they have a history of previous thrombi, then they would be put on something more prophylactically, but we don't start anything prophylactically off the bat. So. Cardiovascular disease, so pericarditis is going to be your most common manifestation. It occurs in about 38% of patients. Usually it occurs at the onset of their disease presentation, but you can also see it when they have relapses with flares. Tamponade is pretty rare. It occurs maybe in 6% of these patients. And of course, you'll see the typical pericarditis findings at EKG and echo. Myocarditis is something that can be seen with infections and then ischemia as well from coronary artery disease as well as drug toxicity. You rarely perform a biopsy on these patients. I have had several patients that look like they have a normal echo and EKG, and you're like, they keep complaining about chest pain. What's going on? It could be that there is some microscopic inflammation that we're not picking up, but I'm not going to go chasing a biopsy for those patients because that's so invasive. And that's where you kind of use your judgment and look at the overall presentation and see if they're having a flare of their disease. Maybe we need to focus more on targeting and treating that. And then going to endocarditis. So this is going to be a board question for you guys. One of the most common things in endocarditis in lupus patients, you'll see something called Liebman-Sachs endocarditis. It's usually where you see the deposits on the mitral valve that can form. So you can pick this up on an echo. Also can see this with antiphospholipid syndrome patients as well. And then lastly, coronary artery disease, about 4 to 8 times higher in lupus patients, and usually about usually young women with lupus are 50 times more likely to have myocardial infarct. So that is something you can see during their lifetime. So pleuropulmonary disease, restrictive lung disease is usually the most common one that we can see in the long duration of their course. However, the acute ones are more listed below. So restrictive, you would look with PFTs and use that to monitor. Acute presentations, you'll generally see pleuritis and pleural effusions. And then, of course, lupus pneumonitis. This is a hard one. You usually want to get a CT to look at their imaging. You'll see those ground glass opacities. Sometimes you'll see some nodules. You definitely want to rule out any infections in this process, as well as look for any alveolar hemorrhage and embolism. So bronchs are usually really helpful. And then going further into pulmonary alveolar hemorrhage. So yes, using a BAL or a bronch will usually help us diagnose these patients. We can't really see much from a CT. You can see they have active lung disease like I discussed earlier, but then that'll help us decipher if this is more infectious or more chronic in nature with having the alveolar hemorrhage seen. Pulmonary hypertension, usually these patients will have increased pulmonary vascular resistance. You'll pick it up on an echo, and then you can see over time they can have right heart failure, which is then going to increase their risk of death sooner. So generally speaking, we would monitor these patients with echoes to make sure they aren't progressing, and then use the help with cardiology and co-managing to see which medications we should use to decrease their pressures. Pulmonary thromboembolism, again, more common in antiphospholipid syndromes or nephrotic syndrome in the co-management with lupus. So you can sometimes have renal vein thrombosis and de novo. And then lastly, shrinking lung syndrome. So this is unique where you see there's an elevated diaphragm and they kind of lose lung volume over time. So due to the weakness of the diaphragm and the respiratory muscles, they lead to the inflammation and then causes this as a secondary effect. So going into hematologic, anemia of chronic disease is very common in these patients. Most of the time, the anemia is going to be like the normocytic, normochromic. Again, you can always have autoimmune hemolytic anemia with the Coombs positivity in about 10% of patients. Even when they have the Coombs positive, about 30 to 40% of the patients don't actually have hemolysis happening. So every patient's unique in that sense. Iron deficiencies are going to be more common when they have lupus in the setting of GI, pulmonary, or menstrual loss as well. And then aplastic anemia can be seen due to medications, and it's, of course, with immunosuppression with some of our medications. So it can be a side effect of that, as well as lupus-related pure red cell aplasia, although this is very rare. I have yet to see it. Leukopenia, less than 3,000 white blood cells, usually seen in about up to 64% of patients. Generally speaking, we always worry about lymphopenia more than neutropenia in our patients. So when you see a patient with leukopenia, lymphopenia, and you're like, where is this coming from? Obviously, we have several diagnoses now that overlap in this realm. MISC would be a total different one, but it's the first one that comes to mind to me when I think of those things. That is something I always want you to keep on your radar if you're seeing those two. Thrombocytopenia is also present in about 30% of patients. Of course, thrombotic microangiopathies is a more severe form where you'll see the hemolytic anemia and thrombocytopenia with these patients. This would make you think of like TTP or HUS. Those are presentations you would worry about and definitely can coexist. And then lastly, lupus anticoagulant causes thromboembolic events, usually more venous than arterial, and they are at increased risk for having these events in about 30 times greater. Vasculitis, so it can affect small arteries and venules. The most common form of cutaneous lupus is the lovely biopsy finding that always says leukocytoclastic vasculitis. And it's like, what do you do with this? It's so non-specific. It's not going to give you a diagnosis. It just tells you there's inflammation in those vessels and around that area. So usually it looks like this picture where you have a little bit of the erythematous and violaceous punctate or non-blanching rashes. Can be on the palms and soles, but again, it can be anywhere. And then GI, so about 20% of lupus patients have GI manifestations. Abdominal pain can be multifactorial in these patients, including mesenteric vasculitis, such as lupus enteritis, ascites or peritonitis. If you're actually going to go and kind of get some of that peritoneal fluid, you can drain it and test it for lupus markers. So you can do double-stranded DNA complements in there, and you can also look for lupus erythematosus cells. So it's going to be high double-stranded DNA, low complements, similar to like you see in the serum. Pancreatitis is a very rare, but I would say significant manifestation. There's about 20% mortality in these patients. Some patients do just present at their onset of disease that, hey, I have pancreatitis, and they'll have a chronic relapsing course of it. Protein-losing enteropathy, and then intestinal pseudoobstruction. And lastly, about 25% of patients with mild transaminitis that can be present. Usually the transaminitis will improve with steroid treatments. And then the last thing I'll say on the side note, there is such a diagnosis of lupus hepatitis. That is something, obviously, if you've ruled out everything, be like, this is due to their lupus and they're having this inflammation. In those patients, you can use something called the ribosomal P antibody. We also mentioned it in the neuropsychiatric section. There overlaps. It can be used for lupus hepatitis as well as the monitoring. So endocrine hypothyroidism is most common, of course, in these patients with thyroid antibodies in about 40% of patients. And then secondary to lupus endocrinopathies would include type 2 diabetes, adrenal gland failure, growth delay or failure with delayed puberty, ovarian and or testicular dysfunction. So ocular disease, you can see cotton wool spots, which are concerning for retinal vasculitis. Usually you have an occlusion of the central retinal vein with antiphospholipid antibodies or CNS vasculitis, and it can be severe diffuse retinal vasculitis as well. Both of these are associated with visual loss. And going to lymph nodes, so you usually see increased lymphatic tissue, especially with splenomegaly or lymphadenopathy. When you biopsy a lymph node, if it ever shows the histiocytic necrotizing lymphadenitis, this is what's most specific for Kikuchi syndrome. So about 25% of Kikuchi patients go on to evolve into a diagnosis of lupus. So that's where when you have these patients, it's always important to get a biopsy of those lymph nodes so that we can delineate what is this lymph node doing. Because you can be like, yes, it's lupus, but is it really? So that's where you always have to rule it out and see where we're going. And these patients are at increased risk of malignancy, usually about a decade or further into their diagnosis. So lab evaluation, basic labs that we recommend anyone to work up in a patient that's concerning for lupus would include a blood cell count, a metabolic panel, sedimentation rate, CRP, and then of course the serology. So we talk about the anti-nuclear antibody. We usually do it by immunofluorescence. This is going to be the most sensitive and specific for lupus. There's a lot of other different forms out there that give you false positive results. Double-stranded DNA, anti-Smith, SSA, SSB, and then the ribonucleotide protein, anti-histone antibody, ribosomal P. Like, we don't test this one regularly, but if you're worried about hepatitis or neuropsych lupus, then you can add that in. Complement 3 and 4, and then the antiphospholipids. So there are a very broad range of antiphospholipids, which I'm not going to delve into. These are the 3 that we usually test for that are more specific in our condition. So lupus anticoagulant, beta-2 glycoprotein, and anticardiolipin. When you have these, you usually want to test it. Say you have a positive result. You retest it about 3 months later to see if it's truly positive and persisting. If it's not, then it's not considered a true positive result to confirm the diagnosis or add to the diagnosis. Just background, the double-stranded DNA is a little bit more sensitive with lupus nephritis, and the Smith is usually very specific for lupus nephritis. So we kind of touched on doing the thyroid already, but also checking the celiac panel. Sometimes you can see an overlap. And then if you're worried about an MAS or HLH presentation, getting those labs with the LDH, triglycerides, fibrinogen, and the ferritin as well. Imaging wise, kind of based on the patient, but baseline chest x-ray is always useful to have. If you're worried about arthritis, you can get x-rays of those joints that are involved. Of course, any cardiac manifestations, you're going to do an EKG and echo. It kind of varies in everyone's practice if they get an echo at baseline or they just do it when they have cardiac manifestations. I trained somewhere where we did an echo at baseline with new diagnoses. So then we have that as like, oh, we did it at the beginning. And then when they had cardiac manifestations later, we can always use it to compare. Renal ultrasounds usually done, of course, with any renal involvements, pulmonary function tests, and then other imaging guided by exam. So criteria. So these are the older criteria. I just wanted to show you how different it looks. So the ACR on the left, this one was from like the 90s. It was like 97, I believe. And then the SLIC criteria was from 2012. So you used to hear people say like, hey, I need 4 out of the 11 criteria to be positive. That was a common thing people used to say. However, we have a newer criteria that came out in 2019. So the ACR EULAR criteria came out in 2019. It is more sensitive at 96% and specific at 93%. So this is going to be your go-to when you're like, I am really not sure what's happening. So the first thing listed at the top says you have a positive ANA with a titer of 1 to 80 or more to classify and go further through this criteria to work up the lupus. So on the left, you'll see the clinical domains and criteria. This will include if the patient has fevers, leukopenia, thrombocytopenia, autoimmune hemolysis, and then the neuropsych symptoms of delirium, psychosis, seizures, mucocutaneous things such as the non-scarring alopecia, any oral ulcers, any subcutaneous findings, or acute cutaneous lupus. And then serosal would include pleural and pericardial effusions, as well as acute pericarditis. and then joint involvement, and then of course renal manifestations. So whether that be proteinuria or they have a biopsy proven lupus nephritis. On the right side, you will see the immunology domain. So this includes the antiphospholipid antibodies, the complements, and then those double-stranded DNA and Smith. So your total has to be at a score of 10 or more in order to give the diagnosis. So some of these patients will linger at 9 and we'll be like, okay, we're going to keep following you and see if you flip the switch over to lupus. And those are always a little bit more of just watchful waiting and give supportive care if we need to along the way. So yeah, this is the main criteria that if you ever want to reference, I highly recommend it. Of course, you have us too. You can call us with questions. Macrophage activation syndrome. So this is usually incident in about 9% of these patients. Their presentation includes fever, pancytopenia, hepatosplenomegaly, hepatic dysfunction, coagulation abnormalities, encephalopathy, and an elevated ferritin. If you did a bone marrow biopsy, you're going to see the phagocytosis of hematopoietic cells. Usually this will, if it occurs in lupus patients, usually occurs in about the first 6 months of presentation. And again, it can be triggered with disease flares, infections, or any changes in medications as well. And fever is usually the most common presentation. So I'm gonna not overwhelm you, but give you a little background of the treatments. Steroids, so glucocorticoids are the most common medication we start at the initial presentation just to help with all the inflammation and allow their recovery to begin sooner than waiting for their other meds. So we use it as a bridging therapy. Maintenance dose is usually at the oral 1 to 2 milligrams per kilogram per day. However, when we're trying to start the initial steps, we sometimes will use a word, we do IV pulse solumedrol, which is just IV methylprednisolone. It's just a higher dose. So pulse means 30 milligrams per kilogram. We usually do it once daily for 3 days, and the maximum dose you would give is 1 gram. Ideally, over the whole course of the disease, you want to use the lowest dose of steroids possible and the shortest duration possible. So if we can taper, we taper slowly. Obviously, we don't want to cause an adrenal crisis or anything along the way. And then definitely want to give them support with their bone health with doing vitamin D and calcium as well. Hydroxychloroquine, another medication we commonly use. This is usually dosed at 4 to 6 milligrams per kilogram per day, and it has anti-inflammatory effect as well as antiplatelet and anti-hyperlipidemic. It is our main steroid-sparing agent that was initially used, and then side effect-wise, we worry about retinal toxicity with this, so that's where we recommend all of our patients to go to ophthalmology once a year for screening. It doesn't have to be right at onset of taking it, but as soon as they can. So immunosuppressive meds, these are the second line steroid sparing agents. So we have methotrexate, azathioprine, and mycophenolate. These are probably the more common ones you'll hear us using. But then we do also have a little bit stronger medications like cyclophosphamide. This is used mostly in patients when they have renal or cerebritis, so brain involvements. We use something called the Lupus protocol. The dose is usually 500 milligrams every 2 weeks for a total of 6 doses. So it's usually about 3 months of treatment before we convert over to something like mycophenolate. It's reserved again for those severe disease manifestations. However, it does have many side effects: vomiting, hair loss, gonatotoxicity, hemorrhagic cystitis, bladder cancer, and infertility. We do educate all of our patients about the infertility concerns. Now that egg and sperm banking is becoming more common, that is something we can educate them on. It's usually an insurance thing, and a lot of kids, honestly, it's like we just want to treat them and we don't want to waste and delay. So I think this is something that's being researched and trying to improve the ability for kids to have this as an option before starting their treatments. But then, of course, in our female patients, we use gonadotropin antagonists like Lupron to help preserve their fertility as well. And generally speaking, this is used in class 3 and class 4 lupus nephritis patients, depending on how active it is. Other medications, belimumab, is usually inhibits B lymphocyte stimulators, so it's called BLIS. This was FDA approved in 2011 for adults. It's an IV form that's approved in kids over 5 since 2019, and the subcutaneous form just got approved by the FDA back in May, which is super exciting. Voclosporin is another one. This is an oral calcineurin inhibitor, FDA approved in 2021 for patients with active lupus nephritis, and primarily approved in adults, so 18 and above. And then anifrolumab is a type 1 interferon receptor inhibitor, and this is an IV infusion given every 4 weeks. Again, adult approved as an adjunct treatment. And then rituximab is off-label, but we still use it often. It's an anti-CD20 monoclonal antibody, and this treats recalcitrant complications. Other concepts to be aware of, osteoporosis prevention is going to be key, especially with the use of steroids in these patients. So diet history, supplementing with calcium, vitamin D, annual DEXA scanning if possible. And then cardiovascular risk management, obviously you want to control their blood pressures, their cholesterol levels, weight and exercise is encouraged, avoid tobacco if possible. And then contraception, combined oral contraceptives. This is a common question that every patient in PCP asks. So combined oral contraceptives are safe to use, except if they have a positive antiphospholipid, you want to avoid using the combined one. You want to just do progesterone based. Immunizations, you definitely want to avoid live attenuated vaccines in a lot of our patients with their immunosuppression. And then seasonal H1N1 vaccines, Pneumovax, Menactra, and Gardasil. And then transition care is one of our most difficult hurdles, I think, in the rheumatology world with lupus patients, because there's a high incidence of dropout and non-adherence with their treatments in the transition timeframe. And then you'll see, some of you have probably already seen some of our patients bounce back and you're like, oh, you're an adult. Why are you coming here? They haven't transitioned yet. So morbidity and mortality. Infection, renal failure, and cardiopulmonary disease are the most common. Morbidity is usually just due to the long-term steroid use. Cardiac disease, again, remember, can be very quiet, so it's something that can fester and not really have symptoms and awareness of right off the bat. Okay, so we got through all that material. Just to give you a glimpse of what we're doing here at PCH Rheumatology, you know, we all have this lovely dashboard. So this is something we started, I want to say a year and a half, maybe 2 years ago. We're looking at maybe a year and a half. Inpatient admissions over the last year, so you can kind of see how many of our lupus patients are coming in. We do monitor this weekly, and then at the bottom you can see the graph that shows the unique patients in the last 2 years. These are new diagnoses, so they kind of give you the trend overall. And this is one thing that we started doing. If you look in our rheumatology clinic notes, usually you'll see something called a SLEDAI, and it's a score that we make of, again, their neurological findings and their other clinical manifestations and lab findings. We use this score to use it in another score, so I will get to that in a second. But this kind of shows you the breakdown. So this is a weighted score. So if you look at the top, it's all number 8. This is all for neuropsych manifestations: seizures, psychosis, brain syndrome, visual disturbance, cranial nerve disorders, and headaches, TBA, vasculitis. Those are going to be weighted really heavy. So if anyone has that, your disease is active and we need to do something about it, versus everything else is a little bit lower on the list. And then you're using the score called DORIS. It looks at the patient's SLEDAI, but then also like the physician global assessment scores, if they're on steroids, what medications, how are they doing clinically, looking at their urine and their protein and hematuria as well. So our goal is to get them into low disease and remission. I just put this here to look at. You guys don't need to know this. It's just for your like information. But this is our dashboard that we have compiled that looks at the patients with DORIS, and we can see that our goal is to try to get these patients into remission. So by now we have about 42% of our 185 patients in remission, and patients with remission and low disease is at 66%. I am trailing far behind, but I am the newest addition in my defense. But yes, so this is something we do monitor weekly with our dashboard, and we discuss our patients weekly with active disease. So we have this lovely button that can help us delineate and look into that and discuss it with our colleagues further to come up with other ideas, because sometimes we all hit a wall and we got to look into other realms of medication sometimes. So takeaway points, I always encourage all of you to take a step back, look at the whole presentation. Each patient is very unique, so not everyone follows the textbook pattern of the criteria that was listed before. A positive ANA is necessary to diagnose this lupus, but does not necessarily diagnose lupus alone. And then always reference that ACR 2019 criteria, and ruling out infection and malignancy is going to be key in order for us to move forward with treatments. Any questions?
The neuropsych manifestations apparently like with the or you see that
Yeah, it's a good question.
Repeat the question.
Yeah, so one of our residents asked, are the neuropsych manifestations usually acute, or are they kind of like simmering along? Generally speaking, they are acute in presentation. They will come in like, oh my gosh, I'm having the worst headache of my life, or I'm having a seizure. They're very acutely ill. So you will usually see those in the hospital. It's very rare to see them on the outside. So yeah, go ahead.
Thanks, that was great. I mean, you always obviously struggle with this between ID and rheumatology in terms of initial presentation. Just a quick reminder for, everybody that, venous ulcers that you mentioned, keeping symptoms in mind, especially that majority of those patients are actually teenagers, which is,
Mhm.
being one of the top states with syphilis these days, this is something to keep in mind, but then that throws the confusion with the testing for syphilis, because of the overlap of the RPR and being positive sometimes, and, being false positive sometimes in patients. With lupus. But the other emphasis is also on the yearly screening for
Yeah.
patients on the expressive type. I don't know if you want to comment on this and remind everybody, what are the things that we, want to screen for every year, especially in Arizona.
Yeah.
Patients on the expressive type.
Generally speaking, sorry, Dr. Balan asked question, I'm gonna summarize. What are the yearly screening that we do for our patients with lupus? For our patients, we usually do tuberculosis screening yearly as well as valley fever, just because of the immunosuppression of medications. Of course, we will tailor it to, like, if there's acute presentation of different symptoms, and add that as needed. But yeah, those are probably our yearly definite screening tests right now.
A question from the Zoom audience. Would you further discuss the ANA test platform, which is the most sensitive? You said there's a specific one to send.
Oh, the ANA by immunofluorescence antibody testing is the one that's recommended. So you'll read I don't see it here, but if you do it outside, sometimes at LabCorp, they'll do an ANA direct that gives you more false positive results. And it doesn't give you a number value like a titer or a ratio. It'll just say it's positive. And then you're like, what does that mean? So that's where ANA by immunofluorescence is going to be the best test to do. Other questions?
Are you going to give the questions to the residents?
No. Dr. Hartley really wants me to quiz you guys. So I did leave these for you. They're just prep questions at the end that you guys can use to review. Totally up to you to do on your own time, but there's a few questions, so feel free to go through them.
Somebody in the audience asked, is ours at PCH immunofluorescence? So we just type in ANA.
Yeah, it usually is immunofluorescence here at PCH. Okay, thank you, guys.
There's a photo at the end, so we put
Oh,
on
I'll
the
flip forward.
You guys would be kind enough to pick the cameras and do one question and I'll wait till they'll be great. Very nice.
I didn't put you guys on.
Oh, you're welcome. Yeah.
Yeah. And you heard from the call.
So, we want you to. What would you
Yeah. No, it's actually, the muscle driver, it's not a bias, but make sure. And followed by. Well, where did